This morning I'm joined by my colleague, Councilor Hogan, Councilor Nave, President Hudson, and myself. This morning we are going to talk about the ambulance services with fire departments as well as the agreement with AMR and the details within. So first I'm joined by Chief Mann.
And this is Craig Whitmer from API from the city.
Craig, welcome.
And Craig's been with us from the time we put out the RFP, and we had an RFP committee to ensure that the items we were asking for in the RFP eventually made it into a contract to benefit the citizens. So he's been with us working through our performance metrics, going through data between the city and with AMR. So he's been with us the whole time.
Excellent.
Also with us today, Councilor Bill McGarity from, he's regional director from AMR, and I have our fire department team that has been working on this. So I know I answered a few questions during the study session,
yes.
And I got your questions. We put it in a PowerPoint.
Okay.
It's in the black binder, and we also have it up on the screen.
Excellent.
And I was going to let Craig Whitmer kind of run through that because he kind of organized all of our data and information. And then after that, if it's okay with you, we can answer whatever
Absolutely.
questions you have.
Let's do that. Also, we are joined by Councilor Jones-Rouser with us, so take it away.
Okay, and so in your black binder is the same PowerPoint presentation that's up on the screen. So as Craig is going through, you'll be able to look exactly what he's talking about.
Thank you. Go ahead, Craig.
So, good morning, everyone, and thank you for the opportunity to kind of provide some background and context for how we arrived at the document we arrived at. So just to run through, we're going to provide some framing of the national and local context, provide a summary of how API came in and was able to help support this project. We're going to run through some contract highlights. Happy to focus there discussing performance management and SLAs. And then I think happy to answer any questions that I'm able to, and then obviously the experts who are subject matter experts will be able to provide better information. So if we could move on to the national and local context slide. So Dan, that's the next one. So to frame the issue, we saw a significant increase, and this is data from 2023 through 2024. We saw about nearly a 30% increase in 911 calls in Onondaga County. There's a lack of access to transportation that is well known by this body of about 30% of folks who don't own a car. It's a challenging labor market for EMTs. You have a decrease in positions, and then generally there's a significant lack of access to primary care doctors in Onondaga County. These factors lead to increased ER wait times and generally indicate stressors on the overall healthcare system. So if you recall, around 2023, there were significant concerns around the utilization of the mutual aid network. So in this instance, it was organizations outside of the county sending their ambulances into the city to provide emergency medical services, and that sort of conversation and local reporting motivated us to start a conversation and try to understand what could be done to address it. So moving on to the next slide, please. So it's good to recognize that AMR is a provider of these services across upstate, and we're not the only city that is dealing with this question. As we can discuss a little bit later, we were able to connect with colleagues in Seattle to provide a little bit more context on the performance management side. But this is trying to show that this is not an issue that's local to just Syracuse. It's an issue across cities and across the country, but specifically different communities are handling it in different ways. Next slide, please. So for some background on AMR's history in Syracuse, Eastern Ambulance has been operating in the area for about 70 years. They were the first agency to be providing paramedic level service. really kind of led the way when it came to certain kinds of certifications, service status management. In '96, Eastern Ambulance was acquired by Rural Metro, and in 2015, Rural Metro was acquired by AMR. So while AMR is a subsidiary of GMR, a national organization, the local branch has been working in the community for over 70 years. So we're talking about working with the largest EMS provider in the country. That kind of informs and answers the question of, why was there only one respondent to the RFP? And it's because AMR is one of the largest providers and is the largest provider in the country, and certainly the largest provider in the area, truly the only organization that could effectively respond to the RFP and the city's needs. Next slide, please. So this is a little bit more information about SFD's ambulance organization. So, and Chief, correct me if I'm wrong here, but SFD began operating a 24/7 ambulance service in 2021 in response to the COVID pandemic. So that required a significant amount of administrative work to gain. So you have to demonstrate the need through the certificate of need. And then while SFD has always provided EMS services as part of its function, ramping up into the full 24/7 service was a significant operational impact. So it's important to note here, and happy to talk about it, perhaps in another setting, that the administrative components, so cost of recovery for service, never really matched what was being spent to provide this service. So just a little bit more background. Engine Company 3 is staffed with 4 members. If needed, the ambulance will be deployed with 2 members to provide transport service. And operationally, it severely impacts the fire suppression capabilities and is only done in times of high demand. So for background on the RFP, spring of 2023, we launched the RFP. By March, AMR is the only respondent with a proposal. And then there's obviously time in between that we'll speak to in a bit. But then in July of this year, the RFP committee met and unanimously voted to move forward with AMR's proposal. So the next slide is a summary of API's engagement with this project. So around March of 2024, we were asked to really try to do 2 things. Achieve service level agreements with sort of another party that we didn't really have much leverage or by way of a authority over, which is difficult, and then try to be able to allow SFD to focus more on their core functions. So over the course of this engagement, we did a significant amount of data collection, analysis, validation, internal presentations, working with folks within the mayor's office, working within SFD, conversations with our colleagues in Seattle who ran a similar procurement transformation program that had some really important lessons for us. Worked to develop some scenarios that we understood to be in the best interest of the city, and then kicked off our conversations with AMR in around September. So since September, we've worked with AMR to try to understand and reconcile what are the needs of residents to try to ensure that residents are getting the care they need in a timely fashion, and what is the sort of reasonable basis for a set of reporting mechanisms that can ensure that if there are issues, that they are discussed and properly managed, and that there can be a basis of sort of mutual partnership between sort of 2 core entities providing safety and security for residents. Next slide, please. So after one of the first meetings, AMR and the fire department came out with these sort of shared objectives. So these are kind of goals that make sense for both organizations. So it makes sense to have quarterly command staff meetings. It makes sense to have reporting mechanisms for when staffing levels at AMR may necessitate more strain on SFD systems. Being able to reconcile the dispatch procedures that AMR is doing with what SFD understands, SFD's ability to monitor ambulances when they're in and out of service, establishing rehab protocols, having a CQI committee, which is related to patient outcomes, establishing assistance with transport protocols, establishing joint training initiatives because there is a significant amount of overlap, collaborating on, I think, changes that may be happening at the county level, which I'm sure SFD is happy to have a conversation with outside of this conversation, ensuring that there is someone from AMR who is able to speak to these issues when they come up, defining and holding AMR accountable for its role in the mutual aid network and ensuring that that threshold is set at an appropriate level, evaluating contracts currently in place. So that meant looking at contracts that AMR had with other municipalities across the country and identifying financial impacts that this may have. Next slide, please. So as you can see, around 12 out of 13 of these are addressed and, for lack of a better term, solved for within the contract. We spent several sessions negotiating each of these points to ensure that they're addressed, and there are continuing conversations that are outside of my purview related to county level health. Next slide, please. So when it comes to performance management and SLAs, sort of what can you expect as a standard? We really focused on the most critical calls when it comes to ensuring patient care is delivered appropriately. We wanted to focus on echo calls. And so for us, that meant ensuring that from the moment a call is placed to the moment that care is delivered, that cannot exceed 8 minutes and 59 seconds, more than 10% during the month. And so that covers from any one corner of the city to the other corner of the city, recognizing that, as was discussed previously, the increase in strain on the healthcare system kind of since the COVID-19 pandemic has led to an over-reliance, in a way of saying it, on emergency services for services that may not necessitate an ambulance to be called, right? So if folks are, and I don't like to use the phrase, but a stub toe is not something that you would call an ambulance for, and ensuring that we're holding AMR to their response times on heart attacks, ensuring that we're holding AMR to their response times on the most important and critical cases. And the mutual aid reliance, which is not to exceed 3% of total call volume per month. So when this conversation really began, we were looking at a mutual aid network reliance of around 10%. Over the course of the last, I think, 6 months, it has not gone above, I want to say, 2%. There was one very short period in February that was addressed in the memo that was sent along. But generally speaking, it has been within the threshold of what we are trying to achieve here. There's also these other mechanisms that might not be exactly performance management per se, but they're important to ensure that operationally AMR and SFD are on the same page about what's going on in the system to ensure that residents are able to trust that when they pick up the phone, they're going to get the care that they need. So that includes the monthly reporting and record keeping, which we talk about a little bit more about what's included in those monthly reports and records, memorializing the standard operating procedures so that AMR is able to get the right care when it's needed, and the discretion to downgrade a call. So if a call comes in and it's coded as X by the Onondaga County healthcare system, but upon further conversation, it turns out it may not be as serious. It can be downgraded, but that downgrade must be recorded for posterity. So if folks want to escalate it and say that no care needs to get there faster, that's totally fine. But if you want to say that this person maybe has stubbed their toe rather than broken a bone, then you have to record that and ensure that it's discussed and followed up on.
Let me just ask about that one part.
Sure.
Because in kind of determining what is of most important, how do you plan to do that when we have so many dialects here? Like,
Well, what happens is when I call 911, there's a
Give me
call.
a second, Chief. Why don't we hold those questions, get rid
Okay.
of, so that we,
Okay.
you know.
All right.
Just like we said earlier.
Sure.
oh, I'm sorry, I was
Make record of that question.
Okay.
And then go through the presentation, and then we will dive in. We have a lot of questions to ask our council.
Very fine.
Thank you, Councilor, for the question. So as we're talking about the accountability mechanism, one thing to note is that in our review of Seattle specifically, but other cities around the country, we look at fines and fees for not meeting these kinds of standards. And in Seattle's case, their research showed that even with $1 million in fines and fees, there was no change in the actual performance. So rather than coming at this with a carrot or a stick approach, we really wanted to drill down on what was the most important means of addressing these issues. And so to us, that looked like effective communication and accountability. So there are kind of 3 layers here of how issues for non-performance would escalate. And that would be conversations at the regular weekly meetings. And then if those conversations don't resolve the issues of performance over a period of, I believe, 2 to 3 months, then the next step is to broaden that net to include folks from the mayor's office, perhaps bringing in Onondaga County or other kinds of stakeholders to see if there's a different root cause, and then a public meeting requirement to be able to come and speak to this body and sort of answer the people's questions. So running through the rest of the contract in terms of highlights. So this is a 3-year contract that is eligible for a 2-year renewal. After that, the city is welcome to and has the authority to terminate the contract upon mutual consent with a certain time frame of notice. In going back and forth, as I mentioned earlier, we really wanted to focus on a good foundation of mutual partnership for 2 organizations that play a critical role in safety within the city. So in that, AMR will provide 2 scholarships for city residents for each of their training classes. AMR is committed to visiting high schools and presenting on career opportunities, the establishment and follow through, as is discussed later, of a concern, functionally a complaint hotline. AMR is required to ensure that their ambulances are, I think, not more than 3 or 5 years old. SFD is able to put their ambulances out into service at their discretion. SFD is able to bring in any specialized vehicles that AMR is not able to provide. And AMR and SFD will work on joint training exercises. So this is a little bit more perhaps in the weeds than may be helpful, but happy to discuss. This is the kind of staffing notification system that will be discussed between the 2 operational departments within SFD and AMR. That's ensuring that there is coverage throughout different periods of time, busy seasons, that if there isn't coverage, it's known and can be filled in for appropriately. And this is the sort of call volume to understand exactly what it is that AMR is doing in the community. So you're looking at a pretty consistent 130 to 140 calls a day that AMR is responding to just within the city of Syracuse. So it is a significant service that AMR is providing to the city. And just want to underscore again that there is no cost to the city for this contract associated with payment of any kind. And I think one other important thing to note here is that, to my understanding, the last time there was this kind of a discussion was around 15 years ago. But AMR has never operated within a contract for providing its services to the city. So this would be the first time that there is a contract that is more than sort of a general understanding, but a binding document. And I think, next slide, please. So this is more about what the sort of monthly reports will include discussion on. So your total number of responses, total emergency transports, digging into the data on the distribution of response time. So, can we drill down and say that there seems to be an issue at a certain shift? Maybe there aren't enough folks picking up evening shifts, overnights, et cetera, et cetera. Highlighted here, there's a summary of customer service and operational complaints so that there's a mechanism to be able to address concerns that are coming in. Clinical quality metrics, patient outcomes, response times, those turn calls, and that summary of mutual aid network requests speaks to one of those original motivating factors here of how do we ensure that AMR is appropriately responding to the city's needs so that county partners are not spending time they otherwise could be attending to county needs coming into the city. Next slide, please. And that concludes the presentation.
Thank you so much for the presentation. We will start with Councilor Joan Rouser's question, and then we'll go from there.
So I got your question, Counselor, and I'll start off to give an oversight of how the call works, and then I'll probably ask Mr. McGarry to get up and explain how it's going to work in real life with this contract. But when a constituent calls 911, it goes to the Onondaga County 911 Center, and depending on the level of seriousness and what symptoms that the patient is describing to the call taker, they code the type of response that should happen. Right off the bat, our fire department will go in our pickup trucks or one of our engines, and we'll start providing care. Our response times are within 3 or 4 minutes, and then the ambulance is going to come after that. So the call gets transferred over to the AMR dispatch, and they dispatch their ambulance based on the information that they got from the call taker and the 911 center also. But if you want to, get up and kind of explain, I'll let Mr. McGarry kind of explain how it's going to work in real time with this contract and the accountability part about that.
Okay. Yeah, thanks for having me. Good morning. So as Chief said, when the calls go to the 911 center, they're coded by their call takers, and they come down through an interface to us. So we never actually have verbal contact with those callers, but we do have their contact information. So the lower acuity, the stub toes, the fevers, those type of calls, we'll send not only we'll send a lower level basic EMT ambulance, and we'll save our paramedic ambulances for the strokes, the heart attacks, the cardiac arrest, the high traumas, those kind of things. So we do that now. That's been a practice that we've been doing for several years, and it's something that we track every day. So.
And the goal.
There's no one here from Onondaga County 911. Right?
No, because that system is a total different system outside of the contract that we have. The Onondaga County 911 Center, they interact with every 52 fire departments in the county, all the police agencies, so everything goes through them. But we did have a conversation regarding one of the questions Councilor Majuk had about a study that's going on. But other than that, we can speak about how the system works because we're dealing with it every day. But
I just wanted to know if there was like a translation component to any of it, because with having so many new Americans in the community, are we not understanding some individuals and not taking their cause that serious? So, but we can't answer that question because we're not.
We can't answer that, but I was actually in a meeting over at the Public Safety Building Friday, and the commissioner from the 911 Center was there, and they've got an AI component now in their call-taking system that can understand dozens and dozens of different languages and translate for them. So, and then we also have a language line as well in our center. Mm-hmm. So if we do have a caller on the line that doesn't speak English, we can transfer it and get translation for us.
Okay.
So to follow up with that part of the 911 in the county. So a call come in, it goes to 911. 911 pick it up, reroute it to AMR.
Well, before that happens, depending on the seriousness of it, the fire department will get dispatched
Okay.
to begin treating the patient.
Right. And with that, have we looked at the time interval between when the call goes into the county and into the mutual, right? That's the language, the mutual aid.
Well, the way it works is when the call goes into the county, the first step the county is going to do is call AMR, and then AMR is going to take that information, depending on their call volume
Seriousness
and
of-
what's going on,
okay.
the seriousness of it. They're going to dispatch an ambulance. If for whatever reason they don't have an ambulance available, and that's where that 3% comes in, that we're trying to keep this metric below 3%. If AMR is unable to provide an ambulance, then that's when the mutual aid from the county will come in and provide the ambulance in the city. And AMR, not only do we accept mutual aid, but AMR also provides mutual aid to the county. So it's a give and take process also.
Right. So have we looked at the time interval where when the county receive it versus where you dispatch it to AMR, the SFD? What's that like?
So when the call comes in, one of the first questions they ask is the address of the caller. A lot of that's automatic with cell phones and whatnot. So it's geocoded, gives a location. So if it's in the city and it's a medical call, it's going to come to AMR. So as soon as they geocode it and put that determinant on it, it comes down through an interface instantaneously.
We studied how much it takes.
Seconds. As soon as it's geocoded and has that determinant, it comes down to us.
So basically, when the call goes in, it gets dispatched to the dispatchers who are going to dispatch an ambulance. The only delay is going to be how serious the call is and what ambulance is going to be sent to that particular situation and what's needed to be called. The goal is for the type of emergency that a patient is having is to send the highest level of care that patient needs, and that's what the goal of this system is made to do. And this is what in our performance metrics that we're going to track, we'll be able to track those every month and figure out what calls came in, what the response times were to these questions. We'll be able to track all of those. Before this contract, there was never a situation where we had the authority to get that information. The county could give us information, but it won't be specifically about AMR's response in the city because they are the provider in the city.
So the 9 minutes is from the time of the call getting incepted to the point of the execution.
Yes.
That's what the 9 minutes
To the
is.
front door of the patient's
Right?
house, yes.
That's what the 9 minutes is.
Yep.
Along those lines, I think there was an incident 2 years ago where somebody in Eastwood had a heart attack. I don't know if you remember that.
Yeah, there's definitely several times we've gotten situations that were brought to our attention. I can say I don't remember specifically this particular call, but every time it was brought to our attention, we always were able to sit down with AMR and figure out what exactly happened. Sometimes the call taker thinks it's taken longer than it actually is once we get the reports for the times. Sometimes there's issues with construction and how the ambulance had to get to the location. Sometimes there's other issues that come about, but most of the time, even before this contract, we would get an answer. And I think, if I can recall, I believe that was Counselor maybe Joe Driscoll when he was on the council back then. That came up, and I can't remember the outcome, but we were able to get
Right.
the answer to figure out what exactly happened.
It was tragic. It ended up being person didn't make it, and part of the reason was there was so much delay in ambulance responding that by the time they get there, it was too late.
Yeah, I can't
Yeah.
confirm
So-
that that's
so-
why the person didn't make it, but certainly there was situations that arose during that call. But we got called to somebody that was already in a bad predicament before we got dispatched most of the time anyway. So
Right. So what I'm saying in all of this is to say that it's very challenging to have a comprehensive conversation around this topic without a 911, right? Without the county here, because I think there's a portion of it that is so significant to make because AMR can only respond to what is given, right?
Yes.
SFD can only respond to what is given and how expeditious
Yes.
that communication was.
Yep.
Right?
Yeah, but I will say the fact is when somebody does call, as soon as it gets to the dispatcher, that call is pushed down to AMR and the fire department. So to your point, they do play a huge role because they are the county's 911 center. But when the call gets to the dispatcher, it immediately, like Mr. McGarity said, it immediately sends out an ambulance or immediately sends out to the agencies that should respond. So having the county here, they can go over some of the challenges they may face, but when the call comes in, somebody's immediately getting dispatched once the call taker receives that information.
Chief?
Dan Downs, First Deputy Chief. I think it's important to note that the reason that we got to this contract in the language that's in there, there have been problems in the past. We know that. We've tried to get the answers and all that. What this contract is, the system right now is working. It is being effective. We're getting the answers. We're getting the proper response times. What this contract is memorializing, and they have agreed to let's solidify what's working, because the drop calls where the issues were have significantly declined. And we said, how do we capture this moment in time and put it in writing? And they said, we can do that. So I think the 911 center questions, all that, while it was all working, we said, we're going to capture this and put it in the contract. So that's really what this is. So this is the signatures for when the system's working correctly, and everybody's going to be held to that standard.
And we understand that. It's just, as we contractually hold ourselves accountable to this, there are components that need to be addressed, which is call time, response, and all of this stuff that especially with what we talked about, the study that the county is doing with AMR and the 911 system and all of that. And to be able to be in cohesion with the county, where are we with this, right? And it is tough to hold AMR accountable without county conversation together happening. Because, like I said, as the county dispatch the call, AMR can only do what AMR can do in conjunction with how quickly that was given to them and the coordination between. So that's where I am, and that's where that question of incorporating that study that the county is doing into this, allowing us to really make an informed decision with AMR, with this contract.
Yes, and I would say the contract has given us the authority to have oversight that for 70 years, we never had. Regardless of, we talked to the county about the study, and us having an agreement of how our constituents in the city are going to receive ambulance services and outline with all these metrics, these meetings to make sure that we're holding them accountable, it's only going to strengthen whatever the county is going to do. Because they also provide services in the county also, but this contract is directly regarding what AMR is going to legitimately in a contract do for our constituents. And when they don't meet those standards, like Chief Downs says, now we have a mechanism to sit down and discuss those and get to the bottom of that. I understand the county discussion, but at some point, not having a contract with our city doesn't give us a voice to make Mr. McGarity come to the table. Even with them being the only lone respondent, there's 17 other ambulance services in the county trying to coordinate everything to make sure it works and to make sure it's working in all these villages and towns. When it's kind of disorganized, it's not going to be disorganized in the city now. We've been sitting down for months, meeting dozens of times to make sure that when a 911 caller in our city calls 911, we have the expectation that's in the contract of what that patient should be receiving. So I totally understand the global look at the county contract, but having an agreement with the city and AMR is only going to strengthen whatever goes on in the county. Like you saw the statistics, we have 52,000 ambulance calls per year. Right now, there's no way we can hold any accountability, any transparency to any, discussions like you said about Eastwood. If this happens tomorrow without a contract, Luckily, we can sit down and discuss those things because we have a good working relationship, but they're going to be bound to that in the contract. And that's only going to solidify anything that goes on in the county. And we confirmed that with the EMS director of the county who's overseeing that particular. We discussed that with him because that was one of your questions. But having an agreement of 52,000 calls and how those calls are going to get answered will only solidify the county, whatever the county is going to do.
So so you said there's 17 different ambulance services within
Approximately
the city or
county.
county?
The county,
Okay.
yes.
And so when a call comes in, is it by proximity of who gets the call? How do we determine if AMR is the entity that gets that call?
Chief, I can take that.
Okay.
So each one of those agencies has, as Craig pointed out, a certificate of need for their area, so they're the primary responder in that area. So I'll use NAVAC as an example in the village in North Syracuse. That's their primary agency, so if a call comes in, it's going to go to them first. If they don't have a resource available, then it's going to go to the next closest available in the system. And that's managed up by the County 911 Center.
So it is by proximity.
It is by proximity. Okay, so I guess I'll pivot just slightly to the staffing component. What is the current staffing component, and how do we know that AMR will meet our need solely? But again, I don't know if it is solely, because now you said 17 other that will be called, so I'm not sure.
Yeah.
So the other 17 are mutual aid. So if we don't have a resource readily available, then it goes back to the 911 center. And in the contract, there is a statement in there that says that our dispatch center and the 911 center will coordinate what's the best response.
What's your current number of trucks?
Right now, 32, and we
32.
typically deploy about 25 per day in the system.
25 per day.
25 specifically into the city, or?
35 within AMR in Syracuse,
Okay.
but our typical deployment is about 25.
In the city?
In the system, I would say, because we cover more than just the city.
I have a question.
Yeah.
Are you properly staffed now?
Yes. We have not been, I think we were yellow if you looked at that metric one day. About 3 weeks ago, we coordinated with the fire department, and they put their ambulance in service on a Saturday night, but we're green every day.
Okay, so you're always available, you're always hiring,
Always hired, yes.
always hiring. Is there a goal of how many staff that you will need?
So our current staff in Syracuse is 300 employees.
So they are able to handle all emergencies. Is there been a problem where a person calls 911, they're on hold for 1 to 2 minutes? That can delay it. If there's a call and you're not available, Chief, would you be able to take a call? I'm going to give you an example. If a person who was diabetic is in dire need of immediate assistance, are you able to go to that house and assist that person if AMR is not available at that moment?
Okay, I'll let Chief Pagano
Okay.
answer that question.
Hello, good morning, Deputy Chief Nick Pagano. I oversee the EMS division, and I'm also the 911 liaison for the fire department. So to some of those questions, I'd like to go back, Councilman Joke, your concern about response times and phone call. I don't know if it's been discussed before this body before, but I want you to know that when somebody calls 911, whatever the emergency is, as Mr. McGarity says, as soon as they get an address and a type of call, it's being sent to the appropriate dispatcher. We will still have people on the phone with 911 as a fire truck, as a mini, which is our medical truck, shows up, or as the AMR shows up. So they're still talking, they're still trying to figure out more components of what the call is, but they don't finish the phone call, then say, okay, we need to find an ambulance, we need to find a fire truck. That is all happening at the same time. So those 30 seconds, it's to a dispatcher to hand out. To your point, Counselor, when there is a serious call, there are components that say if it's this, stub toe, fire department doesn't go. But if it's a serious call, excuse me, an individual diabetic having a medical emergency that they're not right, they're altered mental, that would be coded as a fire response, and the closest fire truck with 2 EMTs or higher would get there and begin life-saving care while they figure out what they're doing for an ambulance.
Do you have EMTs assigned at firehouses?
Yes.
All right, so they are there.
Yes, I think we got 380 staffing. I believe we're over 300 of our members are EMTs.
Yeah.
So is there a difference between when there's an emergency, a rescue truck comes to an EMT?
So I'll let Chief Pagano explain.
Okay.
Yeah.
Yep. Hi, Counselor. Okay. So the fire stations are all equipped with, fire engines and the little trucks, minis we call them. And everyone, other than about 10 people in the fire department, are EMTs or higher. So they will respond in a first responder phase, as we call it, and begin initial life-saving care. Apply a defibrillator, start breathing for them, administer Narcan, administer epinephrine, a life-saving means while we wait for the ambulance. So we go to 18,000 calls. Not every ambulance call gets a fire truck, just the serious ones, and there's a whole mechanism to determine which ones we go on.
Oh, it isn't, so Chief, it isn't if somebody's available. In other words, it's like if there's a criteria of serious calls, you go there.
Sure,
It's
yeah.
It's specifically, that's it.
Yep.
So just for clarification on the AMR annual call, so these calls are specifically, the data you provided here. Are these calls specifically in the city,
Yes, sir.
right? Okay, so with this contract going into place, what would this do to the type of call? Because AMR is all over the county, right? So it's all over the county. Would this be able to dedicate some of these trucks specifically to the city, or would it?
So
I guess what I'm asking is, what in the level of prioritizing?
So
how do we?
That's that 3%, right? Out of 100 calls, they could only not go to 3 of those calls, and that's the metric that we have that they're going to hold. We're going to have in the contract that they're going to hold to that standard. They're only going to turn back 3% of those calls, and like Craig Whitmer said, over the last 6 or 7 months with their new staffing model, they've only been turning back 1 to 2% of those calls. So, just a small metrics, out of 100 calls, only 3 per month would be allowed to be turned back into the county system. And that's going to be in the contract. And if they exceed that, that's when we have those monthly meetings that we can figure out what the issues were, whether sometimes there's issues at the hospital where there's wait times that the ambulance has to be freed. There's different situations that might come up of why this might rise above 3%, but we're going to have meetings to discuss those issues every month.
What was the previous percentage of turnbacks?
I think the highest was at 10. I believe it was 10%. I forgot what year that was.
In
but
2022,
2022, it was 10%.
Yeah, 2022.
During COVID.
They were giving back 10% of the calls.
So with stay with 3% for a second. 3% calls that AMR is allowed contractually not to respond to based on the circumstances, right? Right?
The
Now,
availability.
right? Availability.
Yes.
Right?
Can I distinguish something real quick?
Okay.
I wouldn't describe it as not respond to. It's more that AMR may not be in a position to respond appropriately.
Based on circumstances.
Right, exactly.
So with that, there's this from 911 to where the need is, 9 minutes. I know that SFD call time on average is 2 to 3 minutes, right? Why would it take this long to respond to somebody?
I mean,
When you guys can effectively do it in 2 to 3 minutes.
but our fire stations are strategically placed throughout the city, and the stations were built in every neighborhood to be able to get to this calls in a certain amount of time. As far as the response times, right, the goal is when there's the most serious calls is to make sure that they have the ambulances available to respond to those within that 9 minutes. And it's just not the city. These are like national standards. Every city, Buffalo, Rochester, Yonkers, any system, even New York City, who has their own EMS division, they all rely on a mutual aid network. This isn't just something that's going on in Onondaga County. This goes on, I would say, worldwide. There's really no agency, depending on the call volume, depending on what's going on in the hospital, depending on different things that are going on that can answer these calls all the time. That's where that 90% of the time metrics comes in, because the standards have been shown that this is what works and what is reasonably accepted throughout the country, at least. I don't know if you want to speak to that
I don't
also.
think that answered my question, Chief. I'm asking if SFD can respond in 3 minutes, why would it take AMR a leeway of 9 minutes to respond into something that could be done? And go ahead.
To your point, Counselor, as Chief Pagano said, we have the mini that is strategically located with 2 members. Let's pick a area of the city. Let's say the north side where Station 2 is. You're going to send 2 people to that call. The ambulance that's closest is also going to go to that call if it's a serious call. What we also have is the balance of that engine company, the 2 other members on the engine that are there. When the next call comes in, they're also close. We can keep those response times down because the 2 members of the 4 are split. So we can almost handle 2 medical calls at once in a neighborhood. We don't have 2 ambulances in every neighborhood. So that response time, the first call that comes in on the north side that gets handled by the ambulance, the next ambulance probably is coming from downtown or Eastwood or whatever. So the staffing models are different. The reason the system works is we can get there, stabilize that patient, start CPR, put an AED on, do all the life-saving measures that get them back. And then by the time the ambulance with AMR shows up, they will take the transport of a stable patient and get them to the emergency room. So that's one of the reasons why the 2 metrics, I understand your question, why is it 9 for them and 3 for us? Because of the staffing models, we break our engine companies down into basically 2 sets of first responders if needed.
How many trucks do we have, Chief?
How many trucks do we have?
Station, what is it, 11?
10. We have 10 engine companies. And like Chief Down says, there's 4 people on 2 different trucks. So they're able to essentially have 20 responses throughout the city. And the other part about that is when the ambulance is on scene, they're actually going to the hospital, offloading the patient and dealing with that when we're just going back in service and we're ready for the next call. So that also reduces our response times.
Okay, so we have 10 to 11 stations. We have 35 trucks, AMR, dedicated to the city of Syracuse.
25 per day.
25 per day, right?
Yes.
So it's, have we looked at strategically in terms of scheduling to kind of mirror what the way the city is designed? Because we have 25, there is enough capacity to strategically build in each side of town, just like the SFD is doing. That's what I'm asking.
Yes.
So one other data point I think I'd throw out there is an ambulance call is probably about 60 minutes minimum for us to turn around a call. I defer to Chief Pagano, but
How many minutes?
at least 60 minutes. By the
60
time
minutes?
we get to the patient, treat the patient, take him to the hospital, unload the patient at the hospital, now we're ready for our next call. It's about 60 minutes. I'll tell you, this past weekend, it was 3 to 4 hours to offload patients in the ERs. That's how bad the healthcare system is right now. It continues to be, which is why we have 25 ambulances on duty at a time. The fire department could do an EMS call typically probably 10 to 15 minutes. They're back in service, ready to do the next call. So our time on task is much longer because it's the transport and then the turnover of the patient in the emergency room.
And does AMR have a location? Like, do you guys have a?
So we have our headquarters is over on Richmond Ave. And then when we staff our ambulances in the city, the first one that's in service is always downtown. And then we start to strategically locate them around the city.
So
Nobody gets
just
any
to
sleep
piggyback
Richmond
on,
Ave.
Can you say that again?
I said, nobody gets any sleep on Richmond Avenue. Those ambulances are in and out of there all the time.
so based on the numbers, if we have 4 neighborhoods, 4 quadrants, 8 different neighborhoods or so, you could put three ambulances in each of those
South side,
8.
north side.
No, that's 4 quadrants, but it's 8 neighborhoods per those quadrants. So you could put 3 in those. I'm assuming that we have just about a fire station in at least 6 of the 8. So why wouldn't we have 3 ambulances stationed not stationed inside, but at least close to those fire stations on constant rotation?
So what I'll say is, again, back to it, it takes us about an hour to do an ambulance call. We typically are answering between 15 and 20 calls an hour in the city alone. So those ambulances are often on a call. They're not just, yes, on slower days, we're able to sit around the city and give our crews a break, but that's not very often. They're usually moving constantly.
Okay.
So, and we study that all the time. We adjust our staff and deployment plans within the city just to meet response time needs.
What are the most common calls you get? Like today, let's say north side, what type of calls you're going to get today?
It's a mix, but it's a mid-level determinant. So a lot of illness calls, a lot of injuries. Those
So
kind
you
of
also
things.
get, if there's a shooting,
You get those.
all right?
Yep.
So that has to take priority?
Yep.
Maybe.
That would be a high
Maybe
determinant.
someone's on OD, which I see every day. I see the
Dozens.
needles, I get the
Dozens
calls.
of them a day.
So someone calls you, it's a life-saving. So gun shooting, that's the top priority. You gotta get them to you gotta get them to the hospital. Same thing, someone is shooting on dope, all right, or some violent act that's going on, and you're involved, and, but what about the person, if you're short-staffed, who's calling about a diabetic issue or just fell off a ladder? Where do we look at that? Where your resources are being taken away because you have to handle, let's say, criminal activity, which it is. And but look at between criminal activity and non-criminal activity that has to take all your resources, though.
So we don't look at that piece. Again, it's the determinant driven.
Okay.
So the overdoses, the strokes, the heart attacks, the cardiac arrests, those are high priority calls.
So these are all mixed in.
Everything,
regardless.
everything's mixed in.
Okay.
And I think the intent really for me is in this contract is to send the right resource to the right patient.
Right.
In the right time frame. And that's
Well,
what
it
we're
sort of
trying.
formalizes that you're the go-to people in the city, correct?
Yes.
Now, you handle all the back office stuff, the billing and all that?
Yes.
Okay, Chief, where are we with that? We used to talk about that all the time.
So
Does this formalize this?
No, when we stood up our ambulance to run it 24 hours a day, 7 days a week, we had a third-party company do our billing.
Okay.
As far as their billing, they're doing, they're taking care of their billing. Our call, because they have been answering calls, our ambulance has not been responding to as many calls. And so we still have the third-party company, and they just get a percentage of whatever the bill was for that.
Well, it would be interesting, maybe before this contract was put together, if we could have sort of minimalized all this and maybe,
And had AMR do our
Yeah.
billing. I mean,
that would have been, so in effect, we're just making the whole service effective
yes,
and formalized.
yeah, and I understand that, and I guess we could definitely probably look at that.
Probably should look at that.
Yeah.
That would be something
The,
that probably
the
would.
goal is for us to rely on them to provide this service, so we're not doing it as much, and the need wouldn't be as great as when we were running it 24 hours a day, 7 days a week.
Because this
But
contract doesn't have any money in it, right?
there's no money
It's
involved
one
in
of-
it. No.
Probably the first time in 16 years of the council, I won't see that. Usually contract has money in it, but I can see the mutual benefit of this,
Yes. Other cities, Buffalo, Rochester, other cities put out RFPs. They had multiple people respond to the RFP. We had one respondent. I'm just happy that they responded because, they don't have to go into the contract with us because there's no competition right now that could do this amount of work. And so, we discussed the money. Like I said, Buffalo, they for years had a franchise fee. They're not going towards that, and Mr. McGarity could speak to that. Companies are getting away from that because those fees and those costs that go into that take away from the service that we want to provide to the constituents. This goal of this contract is to provide the best service to our constituents when they need it the most. And as we work through that, especially with them being the only one respondent, we wanted to make sure that there was the metrics in place to make that come to life, where the patient that calls gets the appropriate ambulance. And to the conversation, if they're busy because there's so many calls going on, the mutual aid system, which, like I said, occurs in every municipality in every area, we would have to rely on them. And that's just how the system works, not just in Syracuse, but it's just a reality of ambulance transport service systems. That's kind of where we're at when you have a private company. For us, we have our one ambulance. It's a lot to run our one ambulance. To do what they're doing, we would have to take all of their employees, have all the liability. It would be a massive undertaking to do what they're doing. So for them to be able to come and, provide the service that they have been providing, but now have the oversight and, transparency into what happens on each call every month. And also with the staffing, I do want to say, because there is a part of the staffing part of this contract that every day they're calling us, telling us what the staffing is for that day and the next day and the weekend. So it kind of gives us a vision of, what possibilities, problems might happen also. So,
I have a question. It's a little different. It's going to be off the beaten path. Let me ask you this. With all the new streets coming online, how are you guys working that on your GPS? And I'm just going to speak from my point of view. I'm on Solar Street, and I know people have a hard time finding Solar Street. So how do you guys plan to address that?
So our CAD maps and the maps that are available to our crews are updated real time. We're engaged in the community with all the road construction and the road closures every day. That stuff is communicated to the crews.
And I hope so, because I'm not trying to be, I was going to not say anything, but it was an incident with me where your driver couldn't find my street. So it took forever for them to get there to come and get my mother. So I'm just curious to know, how do we address that?
Right now, it's all GPS driven. There's a device in every ambulance that's got the maps and routes them to the call. As long as they're human beings, as long as they follow what they're told to do by the GPS, they should get there when they get there. But it certainly is a challenge, and we're constantly adjusting our deployments based on the road construction in the city of Syracuse and really in the county.
It's not even the road construction, because there's going to be some new streets coming online. So how do you implement that?
Yeah, as those streets are added, they're added into the county 911 CAD computer system, and same with ours.
and we're having meetings monthly, weekly with the 81, the New York State Department of Transportation. We're collectively meeting about operational needs with the changing of the streets when road closures happen. So we're getting that information.
Because we talked about it, Chief, because you know, and I've talked to the administration to try to put a street sign up for Solar Street because it's such a weird street. So
I think in your situation, because off of, in the parking lot, there's a bunch of buildings off of Solar Street into the parking lot that.
the parking lot is actually Solar Street.
Yes, and having those labeled properly, which, should fall on the building owner to make sure those are visible. But I understand what the situation is, and I'll definitely follow up with our DPW and see if there's something that could happen for that section of the area over there, just so people can understand what's going on in that, and especially in that lot where there are multiple buildings and multiple addresses over there.
And have there been any issues with, and this probably does have to do with the county part, that when the county comes in, with the new exit numbers?
The county's in these meetings also with state DOT, so everybody's as familiar as can be with the changes that are occurring.
So with the mitigation measures, there's a point where that is going to be an important element, right?
Yes.
For staffing, you said every morning there's going to be a projection from AMR. This is how much staffing we have, which give the mutual aid at least a chance to kind of, at least from SFD, to kind of figure out their part. How is it now? Because I think going in, there's going to be that. But what is it like now?
We're getting those reports right now, and we're just gonna, standardize those in the contract. So we're getting calls or emails about what the staffing levels are, and we've been meeting. We've been meeting for a year to get this contract squared away, and there's only been one time where we actually had to help supplement when they knew they were going to have a staffing issue. But other than that, we believe that they've been, based on that turnback of calls with the mutual aid system, that 2 and 1%, that shows that they have been answering the calls that they've been dispatched to.
I have a question about the 60-minute offload time frame. So technically, when someone gets to the hospital and they're taken off the ambulance, and then there's paperwork that has to be done. Now, does that require both ambulance participants to be there to do the paperwork, or is there one that can handle paperwork? I'm just, in my mind, and I'm a little crazy, but I'm just thinking that maybe there's a possibility of always having like a tech on waiting, and maybe if there's a tech there waiting at all times, then maybe an ambulance can leave out sooner and leave one tech behind who's doing paperwork, and then now they're the tech on waiting. I don't know, I'm just thinking outside the box.
So I'll talk a little bit about transition of care in the ER. We get there, we unload the patient on our stretcher into the ambulance. The patient's usually physically on our stretcher for a significant period of time.
Okay.
We're never in a scenario where we're just waiting there to do paperwork.
So they're on your stretcher.
We
you
would
can't
not
leave. Okay.
give a call away or not respond to a call to wait to do paperwork.
Okay.
It's electronic. Usually the provider, health caregiver in the back of the ambulance is the one that's going to do that chart for that patient.
Okay.
And then it becomes part of their record in the
So
hospital.
it's technically the stretcher that is, okay.
We can't get the patient off the stretcher because there's no place to put them.
We need to talk to the
Please.
hospitals.
Yep, and
Okay.
Counselor, that's a nationwide problem with hospital wait times. It's probably one of the biggest drawbacks to the services that ambulances can provide, because the more faster they can offload the patient and put them in the proper care in the hospital, they can go back into service just like the fire department does and answer the next call.
Okay.
So that's a significant part of this. And we talked about the 911 center, there's hospitals, there's a lot of things that go into an ambulance transport company, but this contract is really trying to double down on when our patients call, somebody's coming.
Yeah.
All these other factors, we're working through them, and to Craig's point, we've discussed them, we've talked to the county, we understand what goes on in the hospitals, but this contract is to make sure that when our constituents call, we have a contract of who's coming, and they're obligated to come per the contract. And when they can't come, the mutual aid system comes into place, and when that happens too much, we can sit down and have a conversation as to what happened on July 4th when we went to Solar Street, what took so long, and they're going to pull the data, they're going to go over everything, they're going to explain what the patient called, what the problem was, when they arrived, what actually they found, because a lot of times somebody will call and says, I have a heart attack, but it might just be a cramp, So when they get there, we'll be able to get explained to us by AMR what actually happened when AMR got there, and then this process of going to the hospital. And we're going to have all that in our monthly meetings when there are issues. And if, for whatever reason, this information isn't public, because we're going to meet, there is that complaint line that we have. So anybody that has an issue with the service can call the complaint line, and that's the meetings that the chief and the director are going to have and explain whatever complaints that come through the system, which that's another component that we never had. And I'm not sure of many ambulance services that have that in a contract, but I think it's a pretty unique process for our constituents to be able to call and figure out what happened and complain if there is any issues.
Okay, I have one more question. This is probably completely off the record, but not off the record, but not off record, but off topic. How many calls do you get where maybe a family member called concerned about someone else, and then the person refuses?
I was going to ask that question. Refusal.
Once you guys get, you look at them, you assess it, but they refuse to go to the hospital. So
I
how,
would say probably about 40% of our responses result in us maybe not taking a patient to an ER. It might be us treating them and releasing them. To your point, they may refuse treatment because somebody else called for them and they don't want anything to do with going to a hospital. And we also have the ability to take patients to alternative destinations instead of the ER. The psychiatric calls are a good thing. AMR can take patients directly to CPEP. We're the only ambulance that does that. So, and not put that patient in the medical emergency department to try to reduce the strain there. So,
How much time does that take on the refusals?
again, depends on the severity of the call. Anywhere from a few minutes to, we could be there 30, 45 minutes, depending on what we're doing for them before they go. So,
And sometimes they're able to provide care that brings the patient enough health that they don't need to go to the ambulance, to the hospital.
But it's still time consuming.
It's still time consuming. Yes, somebody might have an asthma attack, but if they can go and provide albuterol and calm them down and get their breathing normal, so oftentimes they're treating the patient where they might not have to go also, instead of going to the hospital having that bill.
so 40% of calls are either released, on-site care, or
we don't
a different
we don't
location.
find anybody when we get there. So
Okay.
Probably 40% of our calls don't result in a transport to an emergency room.
And then, Chief, on the reporting side, since this is a public-facing service, with the contract, is there going to be a reporting that the public can read in terms of how this going, or how is the public going to be following this in terms of its effectiveness and the mutual agreement and its execution?
Yes, I think our meetings, we're going to capture the data, and I guess that's one thing we hadn't really discussed is how could that be presented publicly. So that would be, I know the city does a lot of different dashboards and such. I would have to figure out legally, what's proprietary that could be, but whatever's in the contract, I think API, that's right down their alley to help us figure out how to make that become a reality.
I think for public consumption, it would be nice to have that, so long as there's nothing sensitive, obviously, you will, but to make sure that the data, the response time, the effectiveness, all of that, somehow get published for the public to see. I think that for, in terms of both parties holding themselves accountable, thing will make sense.
Okay.
To your point, Counselor, I think the reason we're excited about the contract, we never had access to the data prior to this. Even the fire department didn't have the reporting from AMR to say, how many refusals did you do last month? How many transports? We never got that. That's what's exciting to us about this contract, is for us to be able to get the data as far as proprietary and to the public. I see your point. We need to get it first so that this impacts our operation. So that's the positive, really positive.
And it's
point.
going to help us train better because we're going to know exactly, where those gaps in our training to what they're actually seeing on the street. And it's, like I said, this is about giving the patient that actually needs an ambulance to get the fire department and AMR to come and make sure we're trained. And this information is going to help us be more prepared also.
Can we make sure that somehow, Joe, that the reporting component into the data system where, if somebody's looking for research, study, so the public can know how's their operation going, is there a way we can incorporate this into this contract, or at least into the legislation, to make sure that is?
Well, it would be best in the contract, but we'd need mutual agreement.
Can we explore that?
I don't think it's something that we contemplated. I think it's a great suggestion. Happy to have a conversation about it.
Okay. Any other questions?
I had a question. So the study session is Wednesday. I know this was held. Have we answered all your questions for the study session coming up?
Well, so far.
Say that again.
So far,
Okay.
it's looking good. We don't know
Okay.
what tomorrow will bring,
Okay.
the next day.
Yeah,
As
we-
you can see, there's 10 of us total with the president, and there's
Yes.
There's only 5 of
Yeah.
us here. Half
Yeah.
of the group is not here.
Yeah, we've done our best to try to answer all the questions, and yeah, just if there's any more, just please let me know and I'll get the answers.
We appreciate it.
Yeah, thank you.
We appreciate it. Yeah, let's look at, Craig, let's look at that reporting component. And I think, if nothing else, I want to thank AMR. I want to thank Fire Department and all the parties involved. Councilors, thank you. That will conclude our meeting.
Thank
Thank
you.
you.
Thank you, Chief.
Thanks, Chief. Thanks, Chief. Thanks, Councilman.
Hey, I got you something.